Hello, everyone. I want to welcome you all to today's webinar speaker series provided by the PA Care Partnership in association with the Office of Mental Health and Substance Abuse Services, which is OMSAS. We would like you to please note the process for continuing education credits has changed. Information will be available at the end of today's presentation for the education credits for this webinar or for a certificate of attendance. This information is also available in the email you received from us today. If you have any questions for our presenter during the presentation, please type them into the Q&A feature, which you will find by running your mouse along the bottom of the Zoom screen. We will get to as many of your questions as we can after the presentation. Today's moderators are Nancy Massey, our social marketing specialist, and myself, Jamal Ford, Youth Resources Coordinator for the PA Care Partnership. We will be monitoring chat and Q&A.
Welcome, everyone. I'm Nancy Massey, and I'm here to tell you that for those of you who were with us on our part one with Dan, you'll notice a little bit of a difference with part two. We're going to be a little bit more interactive and bringing questions to Dan as they come in. So please be sure if you have any questions to share them in the Q&A, and Jamal or I will be bringing them to Dan's attention. If you have any comments, you're also welcome to use the chat. And if you have any other answers, any other questions, I'll do my best to answer them. So at this point, I would like to say thank you for Dan for being with us today and welcome.
Okay, thanks a lot, Nancy and Jamal, and thank you all for being here. And this is really a continuation of the first session that I did on the 13th, I believe it was. So for those of you who were at that session, I appreciate it. And for those of you who weren't, you missed out. I will, actually, I will, somebody asked about a PowerPoint, and I will share that. I will send that to Jamal and Nancy afterwards, one that they might be able to share with you. So again, my contact information, if I can be helpful after the session today. My email, the K and the S in my email are the reverse of the K and the S in my name. So my email is ddubovksy@verizon.net. And feel free to email me if I can be helpful. Just for those of you who weren't at the first session, a little bit of background on me. I'm a social worker by trade, a clinician. I started out working as a child care worker in residential treatment with children and adolescents with mental illness in New York City. It was my favorite job. I absolutely loved it. I did that for about 5 years and then went back and got a master's in social work and then worked as a therapist in another residential treatment center with children, adolescents, and young adults and their families. They ranged in age from about 6 to 25 years old. Did that for about 5 years and then did outpatient work for a while, worked in individual, marital, family, and group therapy. And then did medical social work, worked in oncology for quite a while. My favorite part of that was actually working with adolescents with bone tumors who taught me an incredible amount about how important the quality of life is, not the quantity of life. And then worked in and supervised social workers in acute care locked psychiatric units in a community-based hospital, worked in HIV and AIDS, and then spent about 8.5 years working with what is now part of Drexel University Behavioral Healthcare Education, providing training in mental health and substance use to the eastern part of Pennsylvania. And then for 15 years, I was the FASD specialist for the SAMHSA, Substance Abuse and Mental Health Services Administration FASD Center for Excellence, based outside of Washington, D.C. until 2016, when the government defunded the center. So, and the reason I got involved in FASD 35 or 40 years ago was my son, Bill. And he was diagnosed with FAS when he was 19 years old. And that meant 19 years of failing in every system of care. So what I wanted to start off with today is talking about the brain issues in FASD, because this is a brain-based disorder. And the key really in understanding the behaviors is understanding the brain. And we know that across, as I said the first time, across the spectrum of FASD, from mild deficits to severe, and from lower IQ to higher IQ, like genius level IQ, we see brain damage. And brain damage then doesn't have to do with intelligence. It just has to do with how certain structures of the brain are working. And the experts in brain research in FASD have said that the behaviors we typically see are due to the damage in the brain. They are not willful, purposeful behaviors. And therefore, our typical reward and consequence approach for those behaviors is not going to be effective, and it's actually going to be contraindicated, because if the behaviors aren't willful and purposeful, then a reward and consequence isn't really going to work. So understanding the structures of the brain that are damaged and what those structures do help inform us with what we need to do differently and why in FASD. So my favorite quote about the brain is, if the brain were so simple that we could understand it, we'd be so simple that we couldn't. We are really in our infancy in understanding the brain and how it works. Sorry. We know, stop. Sorry. We know about 1,000% more than we did 10 years ago, because we have much better brain imaging techniques. And 10 years from now, we'll probably know a whole lot more than we do now. So this is really a snapshot of some of the structures of the brain that we know are damaged by prenatal alcohol exposure. Some structures seem to be damaged more than others. We don't know why. And then what we believe these structures do. Every structure in the brain has multiple functions, and different structures have overlapping functions. And there are a lot of different ways of looking at the brain. This is just one way. So the basal ganglia of the brain is a group of structures in the back of the brain that we know is responsible for motor movement. And we know that because there have been years of research in Parkinson's disease, which is a motor movement disorder, where we see damage in the basal ganglia. How that translates then for those with an FASD is that they often have fine motor coordination problems, gross motor coordination problems, and balance problems. Now, the fine motor coordination problems really come into play early, when kids are maybe in around 2nd grade, when they're beginning to learn cursive writing. And I know that a lot of schools eliminated cursive writing a number of years ago, and now it's coming back because they realize that people couldn't even sign their name because they never learned cursive writing. But when you learn cursive writing, you have to follow the dotted lines for the letters to practice cursive writing. And if you don't stay on the dotted lines, you may get a 0 or an F, and that's going to help you concentrate and stay on those lines. Well, if the problem with staying on the lines is fine motor coordination problem, then you'll just keep getting 0s or Fs, and then you'll just feel bad about yourself. People with an FASD often have really terrible handwriting, which is another fine motor coordination issue. They often have gross motor coordination problems, so they appear to be really clumsy sometimes. They may break things, they may drop things. And again, we may view that as purposeful behavior, and it's not at all. So that if they have those fine and gross motor coordination problems, then getting them involved in early occupational therapy and physical therapy can be very, very helpful. Also, the balance problems means that they may fall more frequently. They may hit their head and suffer a blunt head trauma on top of the FASD. And the balance problems seem to come to go into adolescence. And again, that seems to be damage in the basal ganglia of the brain. So being aware of that those motor coordination issues may come up, and how do we address them is really important. But then there's another structure within the basal ganglia called the caudate nucleus. And the research is finding that even when the overall brain size is smaller than it should be with many people with an FASD, And in some people with an FASD, the brain size is smaller than it should be because alcohol has killed so many brain cells during early brain development. That even when the brain is smaller than it should be, the caudate nucleus is even smaller than it should be for that brain size. So that means that this is a structure exquisitely targeted by alcohol. We don't know why, but we know it is. And the caudate nucleus seems to have responsibilities for cognition and emotion. What you will see is that the hippocampus also has responsible for emotion. So this is emotion and the expression of emotion. And cognition, cognitive abilities, which is why across the IQ span in FASD, we see cognitive impairments, probably due to damage, at least partially, in the caudate nucleus. But what I really want to talk about is this piece about emotion and the expression of emotion. Because what I hear a lot from people, from both families and from professionals dealing with people with an FASD, is this person has no conscience and no remorse. Somebody gets hurt and they start laughing. They hurt somebody and they are smiling and laughing. You're talking with them about the seriousness of what they've done and they're smiling and they're looking around, and it feels like they have no conscience and no remorse. They get into court, the judge is talking to them about what's happened, and they're looking around and they're waving at their friends, and judges think that they have no conscience and no remorse. What I think is most frequently the case is that there's a disconnect between what they are feeling and how that feeling is expressed facially and verbally, probably due to damage in the caudate nucleus and the hippocampus. We don't respond to people based on what they feel. We respond to people based on what we see. So again, if somebody gets hurt and they are laughing, we respond that they have no conscience. They hurt somebody and they're smiling, they have no conscience, because that's what we see. But that might not be what's going on. There may be this disconnect. Now, there's been research, long research, on the development of affect regulation, which is the ability to put words and facial expressions to the entire range of feelings. If you have not developed good early affect regulation, either because there's been inconsistent caregiving, because you have moved around from place to place to place and not had consistent caregiving, because your caregivers had issues of their own, mental health issues of their own, or because you are not able to take that information in, you may not have developed good early affect regulation. And again, if you don't have the ability to put words and facial expressions to feelings like anger, frustration, stress, and anxiety, the only way you have to express those feelings is action, and action is aggression. And that's why we see so many of these individuals being labeled as aggressive. But maybe the problem is that they never developed good early affect regulation. We can help with that, but we have to model the range of affect by putting words and facial expressions to the range of affect. That's done, that begins about 2 to 3 months of life after birth. That's when infants begin to learn affect regulation by modeling the affect of their primary caregiver. So we need to go back to do that and model for them words and facial expressions to the entire range of feelings. And with my son, Bill, I noticed that he had a very angry expression often that looked like he was going to attack somebody. And again, if people see that expression, they don't respond like, oh, he must be in a good mood. They respond, he's ready to attack. I have to either attack first or I have to get out of there. And what I realized over time was that he had the same facial expression no matter what he was feeling. And I had to take him to a mirror and practice different facial expressions for different feelings and do that repeatedly. And those charts that have how are you feeling today with the different faces, those can be really helpful. But again, it's recognizing the damage in the caudate nucleus and the hippocampus in this case with emotion and the expression of emotion makes it appear often that they have no conscience and no remorse. So we can't just jump to that.
Dan?
Yeah.
When you're talking about this emotions and being in the mirror, is this a resource or something that may be available to people to help people in a social services setting maybe?
Is what a resource?
standing in front of that mirror and learning how to make the faces?
Oh, I think it helps. Sure, it helps to practice different facial expressions for different feelings.
But if people wanted to get that service, how would they do that?
Oh, it's not a service.
Okay.
I mean, there's no specific service. It really is, you know, taking the person and standing in front of a mirror with them and asking them, you know, show me a happy face. And then you show them a happy face, and then you have them practice it so that they can see their own face and what it looks like. That's what I'm talking about. So it's not a
So
service.
that's up to the family to do
Yeah.
that. And they may
Or
not even
professional.
know that that's something that they could do to help because they're not getting that professional help.
Right. I mean, families can do it, professionals can do it. If the individual is in a, you know, some type of setting, I mean, anybody can do that, but it really is, it's just recognizing, you know, what is going on. Is there a disconnect between what they're saying they're feeling and what they look like? That would be the key to say, we need to address this. And we need to address affect regulation and the development of affect regulation, which means that we need to be able to model words and facial expressions to the range of feelings. You know, if you're living in a family where all the youngster sees early on is aggression, then they don't learn good affect regulation. There was a study that was done a long time ago that found that children whose mothers had severe depression don't develop good affect regulation because all they see is sad or flat affect. So it's incumbent on us to then be able to, in a sense, teach affect regulation. And if they don't develop good affect regulation, then behaviors that we see often look like acting out behaviors. That may be just an indication that they haven't developed good early affect regulation. So I hope that helps.
No, that did help, Dan. Thank you. And it's also disturbing to me that this is not part of a service that anyone, you know, with FASD could easily have.
Well, again, I mean, it's being aware of what the issues are, and that's why we're doing this.
Right.
So the corpus callosum is a bundle of fibers that connects the two halves in the brain. In this slide here, it's right above that white thing in the middle. It's this curve-shaped body. And in FASD, it's often smaller than it should be, kind of thinner, especially in the back part of the brain. And sometimes it doesn't exist at all. Nobody knows exactly what the corpus callosum does, haven't figured that out yet. But it seems that in all, this is my hypothesis, that in all disorders where we see problems in social communication, reading nonverbal cues, reading body language, there's damage in the corpus callosum. We see damage in the corpus callosum in FASD. We see damage in the corpus callosum in autism. We see damage in the corpus callosum in nonverbal learning disabilities, in some individuals with ADHD. So that maybe the corpus callosum has something to do with the ability to read nonverbal cues, body language, and know how to respond, which is a real issue for people with FASD because they can't read that. They can't read body language. They can't read other people's facial expressions and know what's going on with them. And they often make, errors in decisions about what they think is going on. But there was some research that was done with children up until the age of 7 that found that giving kids up before the age of 7 bimanual exercises to do, and a bimanual exercise is anything that uses the two hands independently. So juggling is a great bimanual exercise. Swimming is a great bimanual exercise. Karate is a good bimanual exercise. Playing the keyboard is a really good bimanual exercise. Playing video games with two-handed controllers, not a joystick, is a good bimanual exercise. Anything that uses bimanual exercises increase the thickness of the corpus callosum. We can change brain structure by doing that. Because what it's doing is forcing the two halves of the brain to communicate with each other. Because we know that the right half of the brain controls the left half of the body, and the left half of the brain controls the right half of the body. We've known that for a long time. So that in order to do a bimanual exercise, the two halves of the brain have to communicate, because the right half of the brain has to tell the left half of the body what to do, and the left half of the brain has to tell the right half of the body what to do. Now, does that work with those over the age of 7? We don't know that because that research wasn't funded. Does the increase in the thickness of the corpus callosum translate to better functioning? We don't know because that research wasn't funded, unfortunately. But I haven't heard of too thick a corpus callosum, too many nerve connections across the halves of the brain. So my sense is that we should teach everybody bimanual exercises, or get them to do something that uses bimanual exercises, that it can't hurt, and it certainly could help. The frontal lobes of the brain have a lot of really important functions. They assign meanings to words, as you see here. They're responsible for abstract thinking, and I'll talk more about this because in FASD across the IQ span, we see very, very literal thinking. They help control aggression along with the hippocampus and the amygdala of the brain. They process information. But the two I want to talk about here, the first one here, they help control and process, they help process humor. Now, we think that if we're joking with somebody and they're laughing along with us, that they understand that we're joking with them. What I have found in FASD is that most of the people I've known over the years who have an FASD have a really good sense of humor and can be really, really funny, and absolutely cannot tell if somebody's joking with them or if somebody is serious. And if somebody is joking with them, they typically think the person hates them or is out to get them, because again, they misinterpret what's going on. But they'll laugh along with the person. So my son Bill's 4th grade teacher, years after he got his diagnosis of FAS, said, you know, thinking back, another kid in the class would tell a joke, Bill would laugh along with the rest of the class and then turn to me and say, I don't get it, what's so funny? And that's a red flag we just totally missed. But that's a definite red flag, because they just don't get, you know, humor, but they'll laugh because laughter is controlled in a different area of the brain, but processing humor is controlled in the frontal lobes of the brain in an area that's damaged by prenatal alcohol. If that area of the brain is damaged, we can't really teach somebody to pick up the nuances to figure out if somebody's joking or not. But what we can do is teach them that because of the way their brain works, they're not sure whether somebody's joking with them or not. So they need to check it out before they respond. Are you kidding with me? You joking with me? And I could always tell when I was with Bill that he didn't get somebody was joking with them. And I would say, Bill, they're just joking with you. Don't take it seriously. And he would say, oh, they are, Dad? Okay. And then he was fine. In the same realm, they can't read that Joe over there who's acting out is just having a bad day. It doesn't have anything to do with them. They think Joe's out to get them. So the need to say, Joe's having a bad day, it has nothing to do with you. They can't read those cues. So it's processing humor, and it's also going back to not being able to read those social cues and know what to do. I was doing consulting with a residential program a number of years ago, and a young woman in the program kept on going up and talking with the staff, usually when they were dealing with some crisis. And the staff member would say, I can't talk to you right now. And within a few minutes, she would need to get restrained. She would be acting out and need to get restrained. And I said to the staff, I said, you know, my guess is that she thinks that you hate her. And the staff said, well, she's told us that she thinks we don't like her. And we've said, no, we really do like you. I said, but she can't read that the reason you won't talk with her is because you're busy, even though that's really obvious. So the next time she comes to interrupt you, you need to say, Mary, and that wasn't her name, Mary, I can't talk to you right now. I'm busy. I'll come and get you as soon as I'm done. I'm not mad at you. And then she won't need to be restrained, which is what happened. So, but just, you know, verbalizing that, I'm just joking with you. And it doesn't mean that you don't joke with people with an FASD, because they can be really funny. But it means that when you joke with them, you need to say, I'm just joking with you. So that's an important, and again, that's damage in this area in the frontal lobes of the brain. And then the last one here, I might have talked about this in the first session, but that ability to figure out what to do in a specific situation. So the idea that you tell your child every time you get to the corner, stop and look both ways before you cross the street. And then you find them crossing in the middle of the block. And you say, didn't I tell you to look both ways before you cross the street? They could very well say, you told me when I was at the corner to stop and look both ways, but I wasn't at the corner. And it feels like manipulative behavior. But the ability to figure out, oh, this situation is different, but I need to do what I learned there, or this situation is different, I need to do something different, is a function of this area in the frontal lobes that's damaged. So they can't figure that out. That's why they can't, parents who have an FASD themselves don't tend to learn very well from parenting, sending them to parenting classes. They can't take what they learned in a parenting class and apply it 3 days later when they have their child and their child is doing something. It's not going to work because they can't figure that out. They can't take it from one situation and apply it to another. Oh, I learned this in class. Oh yeah, that's right, I need to do this here. But that figuring out, okay, this situation is different. I really need to do what I learned, or this situation is different. You know, I'm in the middle of the block, but I need to still stop and look both ways. Or it's, this situation is different. I need to do something different. I can't do the same thing. That's
So,
damage. Yeah, go ahead.
Would it be correct to say that those who have FASD tend to be more literal? Like they would more follow what you say sort of to the letter and not kind of think more outside of the box, or put certain situations into the same context that everything would be literal. So if you say cross at the corner, look both ways, they're going to go to a corner and look both ways, but that wouldn't necessarily be the same way for crossing the street and a lot of other different situations, like you said.
Yeah.
Would you take a lot of other situations as being the same?
Yes, absolutely, Jamal. Absolutely. They tend to be very, very literal in their thinking. And again, I'll talk a little bit more about that. But
Okay.
That's a great question. So absolutely.
Thank you.
Mm-hmm. And then the hippocampus is responsible for memory. I'll talk about that in a minute. Learning and taking in new information. And one of the problems is they don't know what's important to remember and what's not. So they'll remember details of something. They'll remember trivia, but not important components. So they can be very good at reading because they're often they sound out words very phonetically, but comprehension and reading is difficult for them. So they'll remember the details of something. Bill could tell you the details of the movie Star Wars that he saw when he was 5 years old. At 12 years old, he could tell, well, then he can certainly remember the 3 things I told him to do. No, it's different memory. And once those details and the trivia is in there, it's like there's no room for the important things. So sometimes it really is, this is important to remember, this is not. Then I talked about emotion and the expression of emotion with the hippocampus, and the hippocampus is also responsible for controlling aggression. And we know that the hippocampus is affected by prenatal alcohol. The amygdala of the brain is an egg-shaped body deep inside the limbic system in the interior of the brain that's responsible for controlling aggression. It helps control stress and anxiety, and I'll talk more about that. And the most important thing, I think, with the amygdala is this is the structure in the brain that's responsible for recognizing danger and fear and knowing what to do. And because this structure is damaged by prenatal alcohol, what we typically see in FASD is that as young children, they have no stranger anxiety. They'll just meet anybody for the first time, give them a big hug, no stranger anxiety at all. And if you say to them, don't talk to strangers, with Jamala, with what you just said, don't talk to strangers, then you find them talking to a stranger. And you say, didn't I tell you not to talk to strangers? Yes. Why were you talking to that stranger? He wasn't a stranger. He told me his name was John. And as soon as they tell them their name, they're not a stranger anymore. So again, that means they're at high risk for repeated abuse and trauma because they have this lack of stranger anxiety. And then as they get older, they don't recognize dangerous people in dangerous situations. You know, if any of us, most of us would not walk down a dark alley by ourselves at 3 o'clock in the morning in a strange city. But if we did, and we heard noises behind us, we would get warning signs of danger. Little hairs on the back of our neck would stand up. We would get this tingling. We would just get these senses of danger and be kind of heightened in awareness. They don't get those signs, which puts them at high risk. This is also why I think we see a lot of people with an unrecognized FASD in our domestic violence programs, and especially those repeatedly in domestic violence. Well, you told me not to go back to him. I didn't go back to him. I went back to this other person who was exactly like the first person. Because again, well, that's a different person. But they don't pick up the danger. Well, yes, he beat me up, but he said that he loves me. And he won't do it again. They don't recognize the danger, puts them at such high risk for repeated abuse and trauma because of that. And that's damage in the amygdala. So kind of the using a natural consequence of you get beaten up by that person, you'll know not to go back to them. That just doesn't work in FASD. It just puts them at risk. But what we need to do, understanding the damage in the amygdala, is role play different situations they may get into that may be dangerous and how we would like them to act in those situations. That's the way to deal with that. Recognizing that this is damage in the amygdala, so our approach needs to be different than kind of that natural consequence approach that we often use. So that's a very quick, not complete view of the brain, certainly, but just a few of these. That when we learn, oh, these structures are damaged, this is what they do, we need to approach this differently. Oh, there is one more thing that I meant to put, I thought it was on this slide, is the myelin. And the myelin is a substance that coats all the nerves in the brain. The way signals are sent in the brain is that an electrical signal is sent down the nerve along the myelin to the end of the nerve that tells the end of the nerve to do something. Either release certain chemicals into the space between the nerves, the synapse, pick up certain chemicals that another nerve has released, pick back up extra chemicals of what they released, and there are about at least 50 neurochemicals in the brain called neurotransmitters, and that's how messages are transmitted. If there is an interruption in the development of myelin, which we see in FASD, then there's more difficulty in messages getting transmitted in the brain. Okay, so we may say, okay, so there's difficulty messages getting transmitted. So what? Well, one of the ways that we see that's manifested in FASD is that it takes people with an FASD often longer to process information. So you tell a person with an FASD, do this right away, and they don't respond right away, we think that they are being oppositional, that they are refusing to do it. It may well be that they need more time to process it. I'm doing a lot of work with the state of Michigan, and they have a couple of parenting programs that talk about things like using timeout. And if your child is misbehaving, you give them a timeout. If they don't respond within 10 seconds, you add timeout. You add more time to the timeout. And if they still don't respond right away, then you take things away from them. It's like that's a setup for those with an FASD to fail, because they're not going to respond within 10 seconds, but not because they don't want to necessarily, but because it takes time for them to process information. My son Bill at one point was in a setting where he wasn't supposed to be there. This is as an adult and at 21, and the police were called, and the police officer said, move, and he didn't move right away. So the police officer grabbed him to move him. And because of his early history in life, the only time he would get physically aggressive is if somebody grabbed him. So of course he hauled off and hit the police officer and ended up in shackles in the hole in jail for 30 days for trespassing. You don't end up in shackles in the hole in jail for trespassing for 30 days. But again, it really was not necessarily that he refused to move, but it takes time to process information. And that's probably damage in the myelin of the brain, at least partly that's probably the reason. So recognizing that and the need to give people with an FASD more time to respond, and then check to make sure that they got what you asked them to do, rather than they didn't respond right away, here's the consequence for that, which we may do with somebody else.
Dan, I
Yeah.
have a question. As you're talking about these different symptoms and how, and it may be something you're going to talk about later, but how people can be misdiagnosed as having a different mental health diagnoses, possibly instead of an FASD, and how, and can you share with us anything that you've learned to make it more easy for people with FASDs to be diagnosed properly?
Well, I mean, one of the problems is we have such a lack of diagnostic capacity. You know, in Pennsylvania, we have one FASD diagnostic center, which is at St. Christopher's Hospital for Children in Philadelphia. There are a few other physicians around the Commonwealth that have been diagnosing this, but with what we think the prevalence is, which we talked about in the first session, it's minuscule. So often they are misdiagnosed because we diagnose people based on their behavior. And they're often misdiagnosed with things like attention deficit hyperactivity disorder, oppositional defiant disorder, conduct disorder, reactive attachment disorder, bipolar disorder. Those are often misdiagnoses because the behaviors look, maybe autism, because the behaviors look similar. But then if we misdiagnose them, we provide the wrong approach for them. I think and the reason because diagnostic capacity is so limited, and for adults it's almost non-existent. It's even more limited than it is for children. Colleagues of mine and I created a screening process, an assessment process to identify those who have a probable FASD, because we need to, the earlier we identify them, the better the long-term outcomes for them. And we need to get this right. We need to identify what's really going on with them. So we did develop we developed a screening process and assessment process. It's been used in a number of places. And actually we have a project that's going on in Luzerne, Wyoming and Wyoming counties here in Pennsylvania, and one that's going to start in Crawford County using that screening and assessment process, and then modifying approaches in working with youth and families. So, I mean, I think we also need to build our diagnostic capacity and build, have more diagnostic centers willing to diagnose people with an FASD. And one of the problems is if you don't have full fetal alcohol syndrome, you need confirmed maternal alcohol exposure to get any other diagnosis on the spectrum. And often we can't get that information. We don't have that information. And part of the reason for that is the stigma that, women are afraid that if they say something about having been drinking even before they knew they were pregnant, Child Protective Services may be called and take their kids away. So they're not even going to admit to it. And we have to get rid of that stigma and that risk, because that's just not helpful at all. So that's another part of the problem in diagnosing, which is why we developed this screening and assessment process that says this is somebody with a probable FASD. They may have other subtle cognitive impairments that still get in the way of appropriate, typical approaches. So if they do screen positive or get assessed as having a probable FASD, then we need to modify what we do with them. So that's a long answer to your question, Nancy.
Well, it's a complicated question too.
Yeah.
As a follow-up, Teresa is asking us, what is the average age of diagnosis?
I would say that if they are diagnosed, it's usually around maybe 7 or 8 years old, because it's usually after they start school. and they have problems in school. If it's diagnosed at all, it's usually diagnosed at that point. But again, probably the vast majority of people with an FASD are not diagnosed correctly.
Makes you wonder how many people are in prison that have an FASD.
Oh yeah, yep.
Mhm.
And how many people are in substance use treatment programs repeatedly who have an FASD? And how many people are in mental health treatment programs repeatedly who have an FASD because they don't respond to the typical approaches? They're not responding to the evidence-based practices like CBT, cognitive behavioral therapy, or motivational interviewing, or trauma-focused CBT. They don't respond to those, or that kind of talk therapy without it being modified. So yeah, I think that there are a number in many of our settings who are not correctly diagnosed.
Thanks, Dan.
Okay, so I wanted to talk about these two studies that to me tell us very, very clearly what we need to do if somebody has an FASD. So this is a study that was done by Susan Astley at the University of Washington. And what Susan did was she used magnetic resonance imaging, which is MRI, magnetic resonance spectroscopy, MRS, and functional MRI or fMRI. Now, magnetic resonance spectroscopy and functional MRI are research techniques at this point. They're not generally available, but they're much more sensitive than a regular MRI. And what Susan found is that there were a number of people who came in for these studies who had a normal MRI done. They had a normal MRI, or an MRI that was done that was read as normal, I should say. And when she used MRS and fMRI, they found significant structural brain damage. So just because somebody's had a normal MRI doesn't mean it's a normal brain. It depends on how that MRI is done and whether it's looking for the kind of damage that we see, for example, in FASD. So in this study, what she did was she took a group of those with a confirmed FASD and a control group with no prenatal exposure. And she matched the two groups and gave them different tasks to do and watched how their brain was functioning as they were doing these tasks. So the task was that I'm going to flash a series of pictures in front of your face and give you this button to push. And when the picture you see is the one you just saw, you press this button. That's called the one back test. And then she puts them in the MRI machines and starts flashing the pictures and watches how their brain is working as they're doing this task, which is the exciting thing about using magnetic resonance imaging, these magnetic resonance imaging techniques. Because other than the being in a tube and loud noise, it's not invasive. And we can look at the structure and functioning of the brain at that moment. And what she found in the one back test is that there was no significant difference in brain function between the two groups. And then she did the two back test, which is when the picture you're looking at is the one you saw two before, you press this button. Put them back in the machine, flash the series of pictures, watching the brain work. And in that test, the two back test, those with an FASD did significantly worse than the control group. And this area of the brain happens to be in the dorsolateral prefrontal cortex of the brain, was not working well enough. It was too slow. So again, you might say, okay, so people with an FASD have a slow dorsolateral prefrontal cortex. So what? Well, the so what is that the dorsolateral prefrontal cortex of the brain seems to be the area of the brain responsible for what we call immediate or working memory. We used to talk about short-term memory and long-term memory. We know now there's at least a third level of memory called working memory. And working memory is what we rely on whenever we tell somebody to do something. If you tell a child, go brush your teeth, get in your pajamas, get ready for bed, you're relying on their working memory to do that. If their working memory is impaired, they may set out to brush their teeth. By the time they get to the bathroom, they have no idea what they're supposed to do next. And it looks like they're being oppositional because they don't do what they're told. A teacher tells a class, take out your math books, turn to page 43 and do problems 1 through 10. He or she is relying on the child's working memory to be able to do that. If their working memory is impaired, first of all, they probably can't find their math book. Even if they find it, by that time they get it out, they have no idea what to do. Then next they start talking to the other kids, maybe get up out of their seat, and then they're seen as a disruptive child. So again, we are constantly giving people multiple directions, multiple instructions. And when they don't follow through, we're saying that they are non-compliant or uncooperative. But if we understand that the working memory is impaired, that means that we have to, first of all, break things down to one step at a time, one direction at a time, one instruction at a time. And it also means we need a lot of repetition, and consistency, which means everybody needs to be doing the same thing with this person. Now, you can't have one person doing one thing and another person trying something, doing something completely different. So one person is using reward and consequence and the other person is not, or one person is really moving towards a positive system, the other one's using reward and consequence. It's not going to work. But lots and lots of repetition. So when we get frustrated by saying we went over this 5 times already, do we have to go over it again? The answer is yes, but not because they're not paying attention, but because of damage in working memory. And that's what's helpful in understanding this is damage in working memory. And understanding that damage means we know how to address it. Now, long-term memory is less impaired. But again, it takes a lot of repetition to get it past damaged working memory into long-term memory. Then we have to work on how to get them to recall the information when they need it. But at least then it's in there. And usually once it's in long-term memory, it's in long-term memory. But lots of consistency and lots of repetition and breaking it down to one step at a time. And then these are studies that were first done by Joanne Weinberg at the University of British Columbia. And Joanne is mostly a basic science researcher. She also works with human beings, but a lot of her early work was with animals, and the animal research in FASD is invaluable to us. It's the one thing that tells us that we know what we're seeing is due to alcohol exposure. It's not due to genetics, it's not due to environment, it's not due to nutrition, it's due to alcohol. So, and Joanne in these studies was studying stress and anxiety. There are 2 parts in our body that control stress and anxiety. One is the amygdala that we know is damaged by prenatal alcohol. And the other is the hypothalamus pituitary adrenal or HPA axis. So what happens is when we are stressed or anxious, our brain, the hypothalamus in the brain sends signals to the pituitary gland to release a hormone from the adrenal glands, which sit on top of the kidneys, called cortisol. A little bit of cortisol is good when we are stressed or anxious. It makes us a bit hypervigilant. But what she's finding is that's not what happens in FASD. A little bit of cortisol is released. So this study, the initial study was done with mice, because we are very much like mice. We have the same bodily systems. And the advantage of mice is we control all the variables, and they have a short gestation, and they have a short lifespan. So she takes 2 sets of mice, one who are prenatally exposed to alcohol and one who are not, same genetic strain, same environment, same nutrition. And she puts them in this gigantic tank of water. It's called the Morris water maze. It's something that's used a lot in psychological studies. There are pictures along the sides of the tank. The water is colored opaque, so you can't see under the surface of the water. And there's a little platform somewhere under the surface of that water in this tank. She puts both sets of mice in the tank. They swim around and they find the platform. They sit on the platform. Then she takes them out of the tank. Then she puts them back in the tank. And within 1 or 2 trials, both sets of mice, those who are prenatally exposed and those who are not, swim right to where the platform is. They know where it is because of the visual cues on the sides of the tank. Then she takes them back out of the tank. And then she moves the platform to another part of the tank. That for mice apparently is a minor stressor. That for me would be a major stressor, but for mice, that's a minor stressor. So what happens is the mice who are not prenatally exposed to alcohol swim to where the platform was. It's not there anymore. They swim around, they find where the new platform is. Not a big deal. They're able to do that. The mice who are prenatally exposed to alcohol swim to where the platform was. It's not there anymore. They panic. They freak out. They melt down. And when she examines them, she finds that there's an over release of cortisol under these minor stressful situations. Well, a lot of cortisol is bad. It causes weight gain, it causes depression, and it causes overreaction. So think about whether you have ever said to somebody or seen somebody where they have seen someone where somebody bumped into them and they punched them, they kicked them, they hit them. Somebody touched their food or their pen and they freaked out. There's a change in their schedule and they had a meltdown. Sorry, they had a meltdown. There is a change in what they expected to eat and they have a tantrum. And we say, you are just overreacting. There's a substitute teacher in school and they act out. You're just overreacting. What we understand from Joanne's research is that it's not just overreacting, it's a physiological body response. So consequencing them for that overreacting is only going to increase the release of cortisol and cause more stress and anxiety. Now, once the cortisol is released, it's too late. You can't get it back. So Joanne's been working on how do we get this kind of hyperexcited HPA axis back down to normal levels. But in the meantime, from my point of view, the implication of this is we need to interrupt the overrelease of cortisol. And the only way to interrupt the overrelease of cortisol is identifying what are the signs that this person is beginning to get stressed, anxious, frustrated, or angry. We all have physiological signs of that, and we often miss them. We need to identify those signs that this person is getting upset. For some people, maybe their face gets red, or they start to shake, or they get really loud, or they clench their fists, or they clench their teeth. What are the signs that they're beginning to get upset? And then what we want to do with them is work with them and identify two things that help them calm down when they get upset. And some people may know what helps them calm down, and most people have no idea. So we're going to identify, and if they have no idea, we're going to practice different things because it's different for different people. For Bill, what he needed to do when he was getting upset is hit a punching bag. For other people, it may be listening to soft music or taking a walk or a little run or doing some deep breathing or guided imagery or putting ice water on their face or on their wrist. All of those things have worked with some people. But we want to identify two. We don't want to give them 7 different things that they can do to calm down. And then what we want to teach them is, you know, when I see you getting upset, I see your face gets red. So when I see that, how about if I let you know, I'll give you a little sign that means go take a chill out. And go take a chill out means do one of those 2 things that I told you to do, that we practiced. But it's got to be immediate. So if the youngster is in school and feeling overwhelmed, he's got to take that break at that moment. He can't wait until the end of the lesson. If somebody is in a group setting and they're feeling overwhelmed, they can't wait until the end of group. What'll happen is they'll just start acting out or disrupting the group. They need to take that chill out. Well, I call it a chill out. They do one of those 2 things that help them calm down, maybe for 2 or 3 minutes, and then come back in. But we have to interrupt the overrelease of cortisol. So that's where I think that these 2 studies are so helpful in saying this is what we often see. This is not willful, purposeful behavior. Therefore, we need to do something different than we would with somebody where it is willful, purposeful behavior.
Dan, just
Yeah.
may I ask this one quick question?
Mhm.
I'm thinking about a young woman that I worked with years past, and she was tiny little thing and had been in a bad accident, TBI, and I was working with her to relearn, some of the skills that she had lost. And after a year, one day, she just freaked out on me, was so strong that she was literally picking up furniture and throwing it at me. And when I got out of the room and got in touch with her social worker, I was told that once she had shown that behavior, I could no longer work with her because it wasn't safe. And it was cut off, and she was no longer going to get that training. And I didn't like having furniture thrown at me, but I was really sad. I wanted to keep working with that, young woman and help her, succeed. I was cut off.
Mhm.
Is that still how that type of situation is handled today?
Oh, I think in a lot of places it is, rather than, okay, how do we help her find other ways to express that anger? There's nothing
Mhm.
wrong with feelings. It's how feelings are expressed. Sometimes we say you shouldn't be angry. It's like there's nothing wrong with being angry. It's how that's expressed that gets them into difficulty. So it's this piece about teaching them when they begin to get upset, what can they do to calm down? I think that we need to do a lot more of that than we typically do.
Mhm.
And after I did a training around this at one point, I think I was in Utah, and I did a follow-up training, and an occupational therapist who had been at the training came back and she said, after the training, I went out and I bought bottles of bubbles, those little bottles of bubbles with a little wand in it. And she said, and I taught the people I was working with to blow large bubbles. And we practiced blowing large bubbles. And she said, and then I labeled the bubbles relaxing bubbles. And I found that they didn't ask for their bubbles to play with, but when they were feeling nervous or anxious, they asked for their relaxing bubbles. Well, what she was doing is teaching them deep breathing, which is a very good relaxation technique and very abstract. So for somebody who's really literal and they're thinking they don't get deep breathing, but this is a very concrete way of teaching deep breathing. And then I had a staff member say, oh, I tried blowing large bubbles. I can't blow them to save my life. I said, that's okay. Then practice blowing a whole series of little bubbles with one breath. Because the idea of blowing large bubbles is you have to take in a deep breath and blow it out very slowly. To blow a whole series of little bubbles with one breath, you have to take in a deep breath and blow it out slowly. And I just thought that was wonderful. That was just such a wonderful idea for one possibility for helping people calm down.
Oh, that's
Yeah.
brilliant. Thank you, Dan.
Yeah. But again,
Mhm.
it's got to be immediate. We can't, it's not like, no, you have to learn control. You have to control you. Then it's not going to work. No, give them something else that they can do. So this
So
is what, yeah, go ahead,
I'm
Jamal.
sorry. Nancy had brought up TBI, traumatic brain injury, and in my personal life, my daughter had a traumatic brain injury, and a lot of what you're talking about, I had experienced after she woke up out of a coma with her.
Mm-hmm.
And I was wondering why FASD isn't treated more like a traumatic brain injury.
Well,
Is it because a traumatic brain injury has a physical component to it, or I'm just like, because there's so many links that I'm seeing, like, and hearing you talk with that correlate between someone who had FASD and my daughter who had a brain tumor that affected all of the areas of the brain that you're talking about. And I was just wondering why isn't it treated in the same manner? It seems that it's kind of hard to get it to be recognized in a sense.
right. That's a great question, Jamal. And there are a lot of similarities between FASD and traumatic brain injury. Some people talk about FASD as a prenatal traumatic brain injury, which in some ways it is. The main differences between like a traumatic brain injury from an accident or something and FASD, the similarities are probably due to similar damage in certain structures of the brain. Typically in TBI, the damage is in surface areas of the brain, maybe the frontal lobes, maybe the surface areas. In FASD, there is damage in those areas, which is where we see the similarities. And then there's also differences because there are also damage in interior structures of the brain that may not be damaged in TBI. And the other thing with TBI is that there's a life before the brain injury. And in FASD, the FASD, it's like lifelong. But you're right that there are a lot of techniques that are very similar. And again, it's similar because there's similar damage in certain structures of the brain, and we can use those. It's like, I always say we don't have to invent something new. We might have to modify what we have. But it's, like traumatic brain injury is recognized, but FASD is not. And I think it has a lot to do with the stigma, and people don't want to look at it, don't want to talk about the effects of alcohol because it's a legal drug. So they don't want to look at it.
Right. Thank you.
That's a great point. So this is what I see over and over again for people with an FASD living with this, is that they're constantly anxious, which again, then there's this high level of cortisol being released. They're frequently frustrated. They really get depressed because they keep failing and they don't understand why they're failing because they don't connect cause and effect. They feel very isolated often. They can't predict their life. They can't predict what's going to happen. They can't predict what's going to happen next. They can't predict consequences of what's going to happen. This is also why they end up in jail repeatedly for the same crime, because they can't predict the consequences. So they end up living in the moment. They suffer ongoing losses because every time they don't meet a milestone that their peers meet, that's another loss for them. Every time they've been moved from one place to another, that's another loss for them. And especially with kids with disabilities, we move them around like they're chess pieces. We move them around from home to home to home. We move them around from class to class to class, and nobody talks about the loss issues, especially with really young kids. And we need to start doing that. They don't really feel in control of their life. There's so much of their life that they feel is out of their control. They have tremendous difficulty understanding the world, and difficulty in everyday life. This is from the Alaska FASD 201 curriculum that I helped develop a number of years ago. Because it's just important to step back and recognize this is what these people are going through every day. And it's just overwhelming. And it's a real struggle sometimes for them because all they're getting is all of these negatives. And we'll talk about how we need to change that. So this is what I see over and over again in people with an FASD. They're very friendly. They're very talkative. This is a real difference between those with an FASD and those with true autism. So when I see somebody diagnosed with autism who is very friendly and very outgoing and will meet me for the first time and give me a big hug, my antenna go up and say, I doubt it's autism. Could be an FASD. They are very friendly. Remember, no stranger anxiety. They really want to be liked, and they really want to be helpful, and they are very, very naive and gullible. So they'll believe anything anyone tells them, anything they see on TV, anything they see in the movies got to be real. Anything they see in a video game got to be real. So those are the things that get them into trouble over and over again. But we'll talk about some of those as strengths as well.
And
yeah,
Barbara, one of the attendees she said, does this make them easily exploited?
Oh, you bet. You bet. Absolutely. First of all, what happens is that they're not accepted by their pro-social peers because, first of all, they are overly friendly. They're often standing in your face. They're interrupting constantly. They appear to be rude. As I said with that young woman, going up and start talking to you in the middle of something. Kids are playing a game. They walk right into the middle of it because they want to play the game. They have no idea, like, to wait for a break or something. And they're, overly friendly, overly intrusive, so they tend to be rejected by their pro-social peers. So they gravitate to the negative peers who see the neon sign on their forehead that says sucker and can manipulate them. And they are easy marks. They are often arrested. They're not the masterminds of major crimes. They're the accomplices. They were just helping out a friend. They, in order to be our friend, you have to go beat that person up. They said mean things about my mother. That's what friends do for each other. Don't worry, you won't get into trouble. In order to be in our gang, you have to go rob this store. We all had to do that. Don't worry, you won't get into trouble. Okay. And of course, they're the ones who get caught. They're always caught. So yeah, they are absolutely easy marks. They're also, at high risk for things like sex trafficking, because again, they'll meet somebody for the first time. There they are. They're their best friend, and they'll do anything because they want to be liked, and they want to have friends. So yeah, absolutely. Another thing is that one day they get it, they do everything they're supposed to, and the next day they don't. And then we think, oh, that's on purpose. They didn't do it because, again, that's willful. No, that's typical in FASD because the brain is just going different ways in different places. It's almost like, I was thinking, it's kind of like if you have a series of file cabinets, right? And file drawers in the file cabinets, and each file drawer has different information. And some days those file drawers open and you can find the information you want. And then the next day you try to go to that same file drawer and it's stuck and you can't get it open. That's kind of what life is like for them. So just because they get it one day doesn't mean they can get it every day. And in some ways they act much older than their chronological age. And in some ways, they act much younger than their chronological age. So they may act like if they're 15 years old, they may act like a 25-year-old, and 15 minutes later, they may act like a 5-year-old. And that's not unusual at all. And in some areas of their life, they are functioning at a much younger age than their chronological age. There's studies that have been done around using adaptive functioning testing. There was an older one with the Myelin adaptive functioning testing that looks at things like communication skills, socialization skills, and daily living skills, and found that 16 or 17-year-olds with an FASD are the ones who were in this study, functioned at around an 8 to 9-year-old level. And the worst was in socialization because that's the most abstract in reading those cues. They did a little bit better in daily living with a lot of routine and consistency. They knew what to do, but even that was only at about a little over 9-year-old level. So again, just recognizing that and not necessarily expecting, and it's not like you treat them like an 8-year-old if they're 17, but again, recognizing, where their areas of struggle are. And again, I talked about the difficulty identifying dangerous people or situations because of the damage in the amygdala, difficulty following multiple directions and rules because of the damage in working memory. They learn best by modeling the behavior of those around them, not by being told what to do or shown what to do or consequence for not doing it, but by modeling. So we need to model with them the right thing to do. And as you said, Jamal, they are very, very literal in their thinking, and that's damage in the frontal lobes of the brain. So if you are literal in your thinking, you do exactly what you are told. There was an example a few months ago of a young man who was having a big house party. This is during the pandemic. And the police were called, and the police came to the house and found out that he had tested positive for the coronavirus. And they said, you tested positive for the coronavirus. How could you have this party? And he said, I know that because I tested positive, I couldn't go out of the house. And I didn't. That's why I had the party here. And he really thought he was doing the right thing. That's literal thinking, right? He knew that you have to quarantine, you have to stay in the house if you're test positive. And he did that. That's literal thinking. So you say to somebody with an FASD, hold your breath, you better tell them, breathe. If you're literal in your thinking, then you can't predict the consequences of your actions. If I do, last time I did this, I got in trouble. If I do it again, I'll get in trouble again. That's why they keep repeating the same negative thing, keep getting into trouble, and keep being surprised. So they do the same thing the fourth time. They've been in trouble 3 times for it. The fourth time they get caught, they're surprised that they're in trouble because they can't predict the consequences. If you're literal in your thinking, you don't get a sense of time, historical time and future time. They're often late for appointments. And you find out that actually they left for their appointment. They had a 3 o'clock appointment. They left their house at 3 o'clock and they don't understand what the problem is. Because the idea takes an hour to get there, so they have to leave an hour before, makes no sense. So I was doing training with an outpatient program around this. And the staff person was working with a woman who was seen as being unmotivated for treatment because she kept on missing all of her outpatient appointments. And when I did the follow-up training, the worker said that she sat down with this woman after the training and programmed into her cell phone when she had to leave for her appointment, not when her appointment was. And she didn't miss another appointment. This was not a lack of motivation. This was a difficulty with a sense of time. How long does it take to get there? The other problem, if you don't really have a good sense of time because you're literal in your thinking, is that you are a very poor witness. You are a very poor victim in terms of being able to defend yourself. So that what often happens with people with an FASD is that the police don't believe them. If they have been victimized, police don't believe them because they keep changing when this happened, when it happened and where it happened, how long ago this happened, because they don't get the sense of time. So, oh, this happened a long time ago and it just happened, or this just happened and it happened a long time ago. And they don't get that sense of time. There was a young man in Canada who was arrested for the rapes and murders of 2 elderly women. He was, they had a trial. He was found guilty. He was sentenced to life in prison. And at some point when he was in prison, somebody realized that when those rapes and murders were committed, he was in jail for some minor crime. He had nothing to do with those rapes and murders, but he could not advocate for himself and say to his lawyer, wait a minute, no, I was in jail when that happened. I had nothing to do with it. He said, I have nothing to do with it, but he couldn't say, where were you when this happened? I don't know, because he didn't have a sense of time. That gets him into a lot of difficulty. And then also, if you're literal, you don't get a sense of space. And this is why often they come up and they stand a half an inch away from people when they're talking to them, because, and then people say, I need my personal space. Talk about an abstract concept. So they are often really come across as really intrusive. If you are literal in your thinking then, and you don't get this sense of time and predicting consequences, then reward and consequence doesn't work. If you want this later, you need to do this now. You can't get this now because of what happened before. No, you got into a fight on Tuesday. You can't go out on a pass on Friday, but I was good today. And they have no idea why they can't go out on a pass. It must be that they're just bad. And then reward and consequence doesn't work for them. Money is another abstract concept. So whatever they have in their hand, they can spend. And lot of difficulty with sarcasm, joking, as I said, joking, sarcasm, metaphors, similes, idioms, proverbs. They don't get any of that. And then the other thing is that although, as I said, they're often very verbal, their verbal expressive language is much better than their receptive language, which means that they can talk the talk, they can repeat what they need to do, they just can't do it. And a colleague of mine once said that having almost every word and what mean. Got that, right? that having an FASD is almost like hearing about every third or fourth word that somebody says and trying to figure out what the person may mean. If you're only taking in every third or fourth word and it's not hearing, it's taking information into the brain and processing it, storing it in the brain, processing it, and recalling it when they need it. If you're only getting every third or fourth word, you're filling in the blanks with what you think the person said, what you think the person wants, you're guessing at it, and you're often getting into trouble. But everything we do relies on verbal receptive language processing. All of our parenting, most of our education is based on auditory learning. Our entire child welfare system is based on verbal receptive language processing skills. Our entire judicial system is based on verbal receptive language processing skills, including things like drug court, mental health court, family court, and treatment is almost always based on verbal receptive language processing skills, much of it. And many of our evidence-based practices are based on verbal receptive language processing skills. And if verbal receptive language processing is impaired, they're not going to do well with the typical approaches unless we modify them. So that's what we need to recognize. It's like we're constantly talking with people and they're nodding their head and they're saying, yep, I know what I need to do. Yeah, I understand. And then we think that they understand and they don't. And then the estimates now are between 50 and 86% of those with an FASD have significant sleep disturbances. And they don't get to sleep, which often happens with those with ADHD, probably because their medication has worn off. But they have difficulty staying asleep. And the difference between ADHD and FASD is that those with true ADHD may have difficulty falling asleep, but once they get to sleep, you can't get them up. You can't get them up and moving in the morning until they have their morning meds. In FASD, the difficulty is they don't get to sleep and they don't stay asleep. And I know families where the kids with FASD literally were up all night long, every single night. And then a family member needed to be up with them to make sure they didn't get into trouble. Exhausting for the entire family, increasing stress, increased anxiety for the whole family. But what happens is for most of us, a typical sleep cycle is about a 90-minute cycle where we have REM sleep, rapid eye movement sleep, and then we go into a deep sleep. And then it's back up to REM sleep and then back to a deep sleep. And the deep sleep is the restful sleep. Well, maybe in FASD, it's more like 10 or 15 minutes, and they never get that deep, restful sleep. So when they get up, they're tired. They're often, they're up and moving, but they're tired. They start to get anxious about sleeping. They may have bedwetting. They may have nightmares. And also there seems to be, they may have more sleep apnea. And it seems that there's some disruption in the body's secretion, normal secretion of melatonin, which helps people get to sleep. It doesn't help people stay asleep, but it helps people get to sleep. So I wanted to try to play one quick piece of a video, if I can. It's, oops. It's called, that's right. Hold on. Sorry. It's called Recovering Hope. Mothers Speak Out About Fetal Alcohol Spectrum Disorders. And okay, I think that's it. Okay. And it's a video that was produced through the FASD Center for Excellence back in about 2003. It's an excellent video. It was developed first for women's substance use treatment programs, and it's mostly women talking about their experiences of drinking during pregnancy and having children with an FASD, trying to get a diagnosis. I like it because it covers different ethnic groups, different socioeconomic statuses. And I know most of the birth mothers on this video, and they are incredible people. But this is, I want to play one piece for you, which is Julie, because she talks about her kids and giving you a sense of kind of the range of issues. Remember, not everybody with an FASD is exactly the same. In this video, you can get it through YouTube. It's not in print anymore from the Center for Excellence because Center for Excellence doesn't exist. And I know that there was a link for a Vermont, what was it, alcohol and drug program where it can link to YouTube, to a YouTube.
Dan, I've
Yeah.
got the YouTube link is in the chat for everyone.
Right, it's in
who
the
wants
chat.
it.
So I'm just
To really understand what FASD is, it helps to meet people who are affected by it. Julie and her husband, Lynn, are foster or adoptive parents to 7 children with FASD. Meeting just a few of their children shows the wide range of effects prenatal alcohol exposure can have.
The youngest one, Cayenne, who is 5, cognitively is on target. Those aren't her areas of weakness. Hers are more in expressive language and especially in sensory integration. She doesn't, like the tags on the inside of her shirt kind of drive her crazy. She has a problem sometimes tuning out other auditory kinds of things that are going on in the background. Her first cousin, Brandon, on the other hand, who is 8.5, Brandon does have full-blown fetal alcohol syndrome, and he was diagnosed at 3.5 months. Brandon's areas of weakness is definitely in cognition. I mean, his IQ is 59. He has difficulty with fine motor skills, so it's hard for him in school to do handwriting and, printing, that kind of thing. Schoolwork is tough for him. Ricky has very obvious neurologic impairment. I mean, he has hand tremors. For the most part, he's very mellow, very friendly, but it doesn't take much. I mean, just like out of the blue, all of a sudden, he could be having a rage. He doesn't really know where it came from, and it's done. It's over with as far as he's concerned. And then he has a hard time understanding why maybe the kid that he was having a fight with isn't over it, And then their older brother, Theodore, who is now 19, and we still have legal guardianship of Theodore as an incapacitated adult. Theodore has a verbal IQ of 55, which is moderately retarded for in the verbal IQ range, and yet you would never know it by looking at him. I mean, he is tall and he's handsome and he's a mother's dream of a son, for the most part. He's compliant, he's respectful, and I can say, Theo, will you take the trash out? And he'll say, okay, Mom. Tessa's IQ is well within the normal range. She has some learning disabilities in math and in written language, but cognitively she's on target as far as her IQ goes. And I have had to fight for services all over the place for her because she doesn't qualify. I mean, so many things are hooked to whether or not you have a low enough IQ, and she just doesn't. And her especially, up until 4th grade, we heard constantly, if she would just be quiet, she could read. If she would just sit still, she could do her math. If she would stop bugging the other kids. I mean, everything was presented as if it was willful and manipulative on her part. And she got raked over the coals at home and at school because we just kept saying, Tessa, settle down. Concentrate here. I know you know these answers. And she really didn't.
After raising numerous adoptive children with FASD, Julie had a startling realization about her own birth daughter.
I've been in recovery for 24 years. I knew that I drank, with my oldest daughter. And yet, I told you, up until 1992, I didn't even know what fetal alcohol syndrome was. So even though I knew that Faith had problems in school that her other 2 sisters didn't, Faith is shorter and tinier than her other sisters, than the rest of the family. I didn't put 2 and 2 together until after I had been taking a bunch of the kids to the clinic. And I remember coming home, and I'd come home from those visits and I'd pull Faith's pictures out, of when she was a little girl and in her early teens. And I'd think, these kids, she looks just like my foster and my adopted children. She just has blonde hair and blue eyes. And I would remember what and how much I drank, when I was 17 and pregnant with her. And finally, when she was 25, I asked her if she would be interested in going to the clinic. And she agreed to go to that clinic. And when I left that day, I was the birth mom of a daughter with fetal alcohol syndrome.
Because FASD can affect children in so many different ways, it can be hard for mothers to tell if their children have been affected by.
Okay. So again, that's just a quick little piece of the video. And I will tell you that, you know, because I've been friendly with Julie over the years, and Brandon, who was the one with the lower IQ, has done really well. He's been in a band. He was an Elvis impersonator for a while. He's doing really, really well. And Tessa, who had the much higher IQ, has struggled her entire life and is still struggling. And I think that that's so typical in FASD. I mean, those who have a lower IQ, those who we reckon, because then we recognize them as having a disability. And I think that that's what, you know, and unfortunately, those who have a higher IQ, we say, you know, no, all their behavior is willful and purposeful. So Jamal,
Dan, we have a,
yeah, go ahead.
we have, yeah, there are several questions here that are all within the same area and are about what you were just talking about. And I'm going to throw them all at you at one time. And so we have one about helping young women with FASD who are pregnant or parenting young children. And what are specific signs of FASD with children from birth to 3? And how do these differences in presentation of symptoms show across cultures? Are they cultural tailored interventions? Are there culturally tailored interventions for FASD? Was that too much at one time?
No, except that, I mean, if we had a long period of time, we could talk more about how do you identify these kids at different ages. We just don't have the time to do that. I mean, we have, you know, we have developed this ability with the screening and assessment to, you know, when we do one birth to 5 and another 6 to 18, and then there's another for adults. So we have a process to do that, but it's a process. And it takes some time to do that. In terms of interventions, there is very little that has been studied around interventions. The only interventions that really have been studied at all, and I mean studied in terms of from a research point of view, have been with children. And there are 4 or 5 that were funded by the Centers for Disease Control and Prevention a number of years ago. So what we do, so we don't have evidence-based practices, but we have practice-based evidence in FASD, and that's really key. So we know what kinds of things work. Part of it is based on understanding of the brain and how it works. We did publish an article in the Journal of Addiction Medicine on treatment modifications in for FASD. And we always have to take cultural issues into account. And, you know, cultural sensitivity is really essential. I don't like the word cultural competence because then people think that they took a class and then now they're culturally competent.
Right.
But I think that we always want to be culturally sensitive and pick that up. There really, as far as I know, they have not identified any like real cultural differences in terms of the prevalence of FASD. I mean, the differences are in terms of communities where women drink as opposed to specific cultures. But, and then, you know, all interventions need to be used through the lens of culture. So I know that's a big answer, and I would, you know, but we don't have the time
to
really fit in.
Sounds like there's 3 webinars in there.
At least. And long-term training. I mean, the training that we're doing with Luzerne, Wyoming it's at least 3.5 full days of training with then, you know, ongoing follow-up to get this practice down. And we're hoping that it'll show that it's beneficial. And there are a couple of agencies that are going to be using it, so we can see, you know, because my belief is if we identify individuals with an FASD, And also it's identifying not just kids, but identifying adults and identifying family members. So it's even those who are working with children where you've given the family member a list of things that they need to do and they haven't followed through, and we label family members as being neglectful or uncaring or sabotaging treatment. And we're just setting them up to fail. We just set these people up to fail over and over again.
Well, I think that you've made that very clear, and I will repeat it because there is no doubt that that's important for something for everyone to take away, that we have set these people up to fail and we don't want to do it anymore.
Right. And the bottom line in terms of intervention, in a sense, is that in FASD, what we need to do is focus on changing the environment, not changing the person. And we're so focused on this person needs to change their behavior. And that's not what works in FASD. What we need to do is change the environment around the person by understanding the person. And that will help the person be more successful. Again, whether they're a child, an adolescent, or an adult. But it's making that shift, which is not an easy shift to make.
Thank you, Dan.
Okay. So again, my experience is that we're a problem-based society. We get paid for dealing with problems. We focus on problems. Our meetings focus on problems. And then we talk about things like finding the right motivating factor. We find what this person likes to do, and then we use it as a reward for good behavior, and we take it away for bad behavior. And then so we're so focused on the negatives. We need to change that. We really need to focus on the positives. And even in Pennsylvania, I used to train intensive case managers in Pennsylvania, and we have a strength-based approach. But even with that strength-based approach, some people think that means you say, well, she has very pretty hair. And from my point of view, that's not what I talk about in terms of strengths. But we need a true strength-based approach where really the focus is we begin with strengths and abilities. And that's one of the things that we're doing, that I've built into this project, is not only assessing the person for an FASD, but also then doing a strengths assessment. With younger children, it's with the caregiver, and with the youth, we do it with the youth and the caregiver separately. But really, it's a whole strengths assessment that needs to be done. And it's done through having discussions with the individual. So we need to move towards what I call a positive focus system of care. And I used to say that it was positive reinforcement. And then somebody told me that they use positive reinforcement. They'll say to somebody, if you do what you're supposed to, then we can go out for dinner. It's like, no, that's not positive reinforcement. That's reward and consequence. Anytime you start a sentence with if or when, or you can't because of what happened before, that's reward and consequence. So a positive focus system of care is utilizing a true strength-based approach, which means we talk about the person's strengths and abilities. We spend time focusing on that. And our goal is to build on those strengths and abilities. It also means we consistently tell the person what they do well and what they're good at. So what I really say to parents and also professionals is, I want you to start out 5 times a day, every single day. I want you to tell this person, whether it's a child or an adolescent or adult, what they do well, what they're doing right. And it may be more small things, and write down everything you have told them, because when something's gone wrong, you will forget anything that you said has gone well. Because people with an FASD and other disabilities have heard over and over and over again what they've done wrong, but they haven't heard enough what they've done right. Let me just, okay, I'll go back. So it doesn't mean we ignore challenging behaviors. We deal with them, but our focus is on building strengths and abilities, building self-esteem and competence. That should be our goal. And we do that by kind of shifting the environment around the person. I was doing some consulting with a treatment program, and they were working with these two young women who had both screened as positive as having a probable FASD. And they wanted me to give them some ideas about treatment for them. And they were having a clinical staff meeting. So they brought each of them up to the staff meeting individually and introduced me to them. And the first question I asked each of them was, what do you do well? And neither of them could answer the question. And that just speaks to me about how much we ignore those positives or just dismiss them. If I had asked them what their problems were, they could have spouted that off in a minute. But asking them what they do well, we have to ask those questions. We have to focus on that. So again, the strengths that people have sometimes cause problems for them, but are also seen as strengths. There may be times you're talking with the family, somebody's talking with the family and say, what do you like about your child? Nothing. Okay, I'll just write that down and we'll go on. No, that means we have some work to do because everybody has strengths and we need to identify them. And we need to identify strengths in the individual, strengths in the family, strengths in the providers, and strengths in the community. And when I talk about community, I talk about the overall community. You know, what's in the community? If this is an individual who really likes art, is there an art program in the community that they can be a part of? But I also talk about their cultural community. So if there are cultural rituals and traditions that they can feel part of, or religious rituals and traditions, that's their culture, that they can feel part of rather than apart from, because they often feel, again, isolated, ostracized, then let's build on that. But never use that as a reward for good behavior and take it away from bad behavior. So these are strengths I see over and over again in people with an FASD. Remember, everybody is different. This is a spectrum, but I do see these things over and over again. The first four here are the same ones you saw before that get them into trouble, but they can also be seen as strengths. So you have this individual who is very friendly, very likable, really wants to be helpful, talking all the time. If they're in some kind of program or a classroom or whatever it is, maybe they could be the tour guide for visitors who come. Maybe they could be the person who helps new people coming into the setting feel comfortable. Maybe they could be the one who helps the whole group get together for a group activity and be quiet and, you know, get them all set for the group activity. Let's build on that. If I said to Bill, go out and mow the lawn or you will be grounded. 10 years later, he would still be grounded and the lawn would not be mowed. If I said to him, Bill, I need help mowing the lawn, would you mind helping me? In 5 minutes, he would be out mowing the lawn. But sometimes we get caught up in, they have to do what we tell them to do, when we tell them to do it, how we tell them to do it, or else. This is the consequence. What I find over and over again in people with an FASD is that they really do want to be helpful. They're often really caring. They worry about other people, but they have no idea how their words or actions affect anybody else because that's abstract. If somebody said that to you, could that hurt your feelings? That, you know, or saying that to somebody can hurt their feelings. That's too abstract. But they really do worry about other people often. They're really hard workers. They're often doing the wrong thing, but they're working really hard at it. So if we get them doing the right thing and doing something they enjoy doing and providing them with the right supports, they can be really good workers. They are often very creative, music, art, dance. Let's tap into that. They are determined, which is a strength-based way of saying stubborn. They will get rejected, come out and try again, get rejected, come back and try again long after we would give up. They have points of insight, and the points of insight are helping them understand how their brain works. And that's really key, that because of the way their brain works, they need to do one step at a time. They can't get 3 verbal directions. If somebody tries to give them 3 verbal directions, they really need to be able to say, wait, just tell me the first thing you want me to do. When I'm done with that, then tell me the next thing. That would give them a point of insight. Many of them are good with little kids. The asterisk is because some of them have sexually inappropriate behavior, often because they're misreading cues. She smiled at me, it meant she wanted to have sex with me. Or they're masturbating in public or in places they shouldn't be. But the majority don't have sexually inappropriate behaviors and can be really good with little kids, really good with the elderly, really good with people with physical disabilities, not good with their peers because their peers remind them there's something different about them. But if they are, let's tap into that. A young man I was working with where he was in 6th grade and his reading was really good. Comprehension was terrible, but reading was good. And he really did well with little kids. And we set him up, I got the school to set him up to read to the kindergarten kids in the library. And I said, same time every day, maybe 15 or 20 minutes, he reads to the kindergarten kids in the library. Don't keep changing days and times because then, because of this difficulty with the sense of time, he won't show up when he's supposed to. And he did that for a number of weeks and he was doing really well and it helped with his whole behavior in school. And then one week he decided he didn't want to go to the library and read to the kids. And the school's response was, well, then you've lost your job. We gave you this responsibility and you took advantage of it. That's it, you're done. And I said, no, you can't do that. What you need to do is go back to him and find out why he didn't want to read that week and say to him, you know, you are so helpful to us. It has been so helpful for you to read to those kids in the library and they really look forward to it. Would you mind helping us out and reading to them in the library again? And he would do it again in a minute. That's using that desire to be helpful. They tend not to be malicious and premeditated in what they do. And even those with an FASD who have killed others, it's not the same maliciousness we see in others. It may be, there was a young man about 19 years old who killed his girlfriend, ended up in jail, couldn't figure out why he was in jail, couldn't figure out why his girlfriend didn't come and visit him in jail, because when people get killed in video games or on TV, they're back again the next show, the next minute. And he absolutely didn't understand it. And every day is a new day for them, which means that they don't hold a grudge. So they can curse you up and down, be furious with you 1 minute, and the next minute they want a hug from you. Just as Julie said with Ricky, you know, he can get into a fight with somebody else and 10 minutes later it's over. And it is over for him. Feels manipulative, but it's not. And doesn't understand why the kid he had a fight with doesn't want to play with him. That's so typical. Every day's a new day. Now, the problem with every day is a day means we went over this yesterday. Do we have to go over it again today? The answer is yes, because every day is a new day. Now, I did a training at another a program, and one of the staff members had a 14-year-old son with an FASD who was very, very angry. Wouldn't eat with the family, wouldn't sit with the family, was never smiled, was really very angry and sullen most of the time. And I got an email from his mother, who was in training, the next day. And she said, I just need to tell you that I went home after the training and I said to my son, I just want to thank you for all of the help you've been giving your younger brother the last few weeks. I really appreciate that. She said, for the first time in months, he smiled, had dinner with the family, hung out for the evening. Now, it's not going to work every day, probably not, but it did work that day. But just her son hearing something positive instead of her going home and saying, okay, what happened today in school? What'd you do wrong? Because that's what happens typically with these kids and adults, is that we constantly are talking with them about what they've done wrong, how they've messed up, and what they need to do differently.
Dan, we have a question for you.
Yeah. Go ahead.
It's anonymous. Are people with FASD more likely to have an addiction later in life?
Okay, good question. And the sense is yes. And the reasons for that are multiple. One of them is that there is a genetic vulnerability for addiction in some people. So that if, for example, this individual's parents or grandparents, because we know that it can skip generations, drank, that may, or had an addiction, that may put them at higher risk. We also know that there's family traditions and family loyalties that put them at higher risk for addiction if addiction is kind of in the family. Also, there's a lot of peer pressure, and because they really want to fit in and they want to be liked and they want to be like everybody else, and they get involved with other people who have an addiction, then they may start using as well to fit in. And the other reason is, as I said, in the first, the beginning of the first webinar, that it is incredibly painful to live with a hidden disability that nobody recognizes. Just as Julie said with Tessa, to be told over and over and over again, you can do it if you want. Just settle down, just pay attention. You know, you're bright and you can do it. You're just not trying hard enough. And they really try and they can't do it. That is so emotionally painful that one of the ways to deal with that emotional pain is to use substances. I understand why we would see that, because it's not a long-term good approach, but I understand, because at least for the moment, it blocks out that emotional pain. So yes, for all of those reasons, they are at higher risk. Do we know exactly what percentage of those with an FASD end up with addictions? No, because again, we're not diagnosing everybody. But we do have a sense that yes, it is significant. And the problem is, then they get into treatment programs that use motivational interviewing and cognitive behavioral therapy and AA and NA and individual and group therapy, and they're lost and it doesn't benefit them. So that's a long answer to that question.
It was, but that again, there's no simple questions in this area. That's for sure.
Yeah.
Dan, we're getting towards the end now, and I think we've gotten to all the questions that people had. And I thought in the last few minutes, maybe there's something that you would like to say to wrap up.
Okay. Yeah, I think that there are, let me just stop this for a minute. Excuse me for a second. I think I have to sneeze. Okay. Yeah, I think that a couple of things. One is, I think it's the key in terms of the person who is, how do you recognize this, or, what does it take? And we can't go into all the details for using the screening and assessment, but the key really is, if somebody isn't responding to the typical approach that works with most people. I mean, the approaches we use, like a reward and consequence approach, whether in school it's a star or sticker or point system, or or at home, and parents are often told you need to use this at home, or it's a privilege system, or it's a pass system, whatever it is, a reward and consequence system. We use those because they work with the majority of people, and they work with people who are more cognitively intact. But if this person is not responding to that, let's not continue to do that. Let's stop and say, maybe we're missing something here. It's like in substance use treatment, what I say is, if this person is back in treatment for the third time, definitely, maybe even the second time, but especially at least the third time, we have to stop saying relapse is part of recovery. Because all we are doing by just saying relapse is part of recovery is saying this person is not yet ready to respond to our program. And when they are ready, then they will respond to our program. Instead, we have to say, what are we missing? What do we need to do differently to help this person succeed? And I think that that's the key. The key question is, how do we help, whether it's a child, adolescent, or an adult, how do we help this person succeed? What do they need in order to be successful? And how do we, as the environment, the community, provide that for them? And I think that that's really the bottom line. So anybody who just doesn't respond to the typical approach, they don't respond to timeout, don't give them more timeout. Don't take things away from them, because all they're going to say is, okay, I don't care. And then you're going to take more things. Because I did that with Bill all the time, before I knew what was going on with him. I would give him timeouts, then I would take things away from him. And he would say, okay, go ahead. And then I would want to find something that he responded to, because the idea is you find the right motivating factor, and then they will do what they need to do to get it. And I'll tell you, in FASD, all that does is set them up to fail and feel frustrated and think that they are just bad because they want those rewards and they can't get them that way. So that's that piece about that true strength-based approach. Let's look at the strengths. Let's build on those strengths. Let's help them feel better about themselves and more positive about themselves with what they are able to do and what they can do and how we can build on that. And again, it's like, how can we help them be successful with whatever it takes? And I think that's the key. So that's one thing. I think the other thing is that if we suspect an FASD in a child or an adolescent, we need to help the family understand their behaviors differently. Again, that their behaviors are not typically willful, purposeful behaviors, but their behaviors are really due to how their brain is functioning. And it's really important because, again, they are at high risk in families of suffering from abuse and trauma because they are difficult kids to raise. So recognizing that. And the other reason timeout is not effective is that the concept of timeout is you need a timeout to think about what you did wrong and think about what you could do differently. And you send them to timeout and they have no idea why they're there. Must be that they're just bad. The other thing I would say for kids and adolescents is we need to stop linking school and home. You know, so many times it's like a kid misbehaves in school and the family is expected to then follow up with that at home. And then these kids hate both home and school. And whatever goes on in school needs to be dealt with in school, not at home. Because I see so many times this kid misbehaved in school, they lose their privileges at home, they have to go to bed early, or they have to, and they have no idea why they have to go to bed early, why they can't play Nintendo, and it must be that they're just bad. And because they don't connect cause and effect in that way, everything we do just sets them up to think that they're just bad, and then they act that way because that becomes their self-image. So I hope that that makes a little sense. And I'll tell you that I know people with an FASD. I know adults with an FASD. Many of them have been in and out of jail. They've been in and out of treatment programs. Those who are doing best as adults are those who have said that they have always had somebody there to support them, somebody they knew they could count on for help when they need it. And that's the goal. The goal is anytime you're not sure about something, here's who you call and here's your backup person. Not you need to figure that out by yourself, but this is who you call. And this is your backup person. Anytime you're not sure, there are no stupid questions. So anytime you're not sure about something, you call me. And if I'm not available, here's who you call, and you know both of us. That is really the goal at helping them be successful. And there are adults with an FASD who are amazingly successful. There's a group of 5 adults with an FASD in Canada. They're called the FASD Changemakers. They have now done 2 international surveys of adults around the world with FASD that are amazing. They've presented it as a webinar. The first survey, the results are written in a chapter in a book that's been published. They are amazing. I've met amazing adults with an FASD who are just wonderful people. I mean, and that's the other thing. They have so many strengths. Let's recognize those and let's tap into those and let's build on those.
And I have 2 quick questions for you.
Okay.
Do you think that, from Charlotte, do you think that video recording therapy would be an intervention that could be considered? And from Lauren, what do you recommend for working with an adult who may have FASD but is not diagnosed? How do you suggest broaching the topic with an adult?
Okay, 2 really good questions. I think the videoing could be useful if the idea is you video it and then you sit down with the person and like break it into little pieces and then talk about what it means and what you see and what they see. You know, it's not just videoing and having them look at it, but it's having that discussion. It's like, even if there's like a group therapy, it's they can be in a group therapy, but somebody needs to sit down with them right after the group and say, this is what went on in group, and this is what it means for you, because that's what they can't take from that. So in those ways, the video recording could be really useful, but again, needs to be broken down into little bits and then talked about in terms of what you have seen and what that means for them. In terms of the second question, which is another great question, I think we start out by saying, you know, I know you've had a lot of difficulty in your life and you've really struggled with a lot of things. And the typical, you know, approaches that have, you know, people have tried with you, you know, haven't really helped you be more successful. You know, so what I'd like to do is let's try, you know, some different things, and let's try breaking things down to one direction or one step at a time. Let's practice doing these things together. Role playing is great because you're modeling for them how you would like them to respond, and you do it repeatedly. And then down the line, if they start to improve and do better and feel better about themselves, then you can talk about, well, you know, one of the reasons why this might have happened, you know, or you might have had trouble with these approaches may be that, you know, it's possible that your mother consumed alcohol even before that she knew she was pregnant with you, because that's one of the things that sometimes we see. So that could be really helpful. You don't have to start out by saying, we're wondering if you may have an FASD. I mean, I would never introduce this, especially with a birth family, with, we want to figure out whether your child has an FASD or your loved one has an FASD, because then you're not going to get anywhere. But talking about the fact that I know you've had, you know, you've really struggled and you've had difficulties, and what we want to do is figure out, you know, why that's happened and what might help you better. So I think that that's a really good way to approach an adult who you suspect might have an FASD, and not necessarily need to talk about that right away.
Thank you, sir. I appreciate that. With that is our time. We're just right out about at 4 o'clock. So Dan, I would like to thank you for such a wonderful and informational presentation on FASD. I know this is a topic that can, you know, be talked about for a long time because there's a lot of nuances and a lot of things that kind of go into it. And I think you did a wonderful job at explaining a lot of those things and answering a lot of the questions that were posed. So I want to thank you for that. Reminder for those seeking continuing education credits, use the link in the email you received today, and that will take you to a PDF with instructions for credits from UPMC. For those attending on Zoom, you will be prompted after the meeting today and through an email tomorrow to participate in a brief survey about the presentation and download your certificate of attendance. This is separate from continuing education credits. The link for the evaluation and certificate of attendance is also included in the email you received today here for the webinar. Our next presentation will be on June 10th. 2021 from 2 to 4 p.m. with Daniel Hughes, and a great panel to discuss building trust with children who have been hurt in relationships. We look forward to having you join us then. So thank you all for coming today to such a wonderful presentation, and have a good evening.
Right, and I want to
Thank you,
thank
Dan.
everybody for being here also and for being interested in this.
Thank you.
Thank you.